Hey folks, welcome to So-Called Normal. I'm Mark Henick. Today on the show, we have Dr. Ian Dawe. Ian's my friend. All of the guests so far have been my friends. That's who I want to talk to. I want to talk to my friends. But Dr. Ian Dawe is the program chief of mental health at Trillium Health Partners, a psychiatrist who's super passionate about what's called the zero suicide movement. This idea that we can achieve a zero number of suicides. You know, right now in Canada, there's more than 4,000 suicides every year. In the United States, there's more than 40,000 suicides every year. Around the world, there's more than 800,000 suicides every single year, more than murder and war combined. But nobody ever talks about that. I mean, I talk about it all the time, and Ian Dawe does too. And he's so passionate about it. It's extraordinary. He's one of the good ones. Not to say that there are bad ones out there, but there might be bad ones out there too. And I think that it's so inspiring for me to see a psychiatrist, especially. And we get into this a little bit about how, I'm by no means anti-psychiatry. I'm very pro-psychiatry. I have a psychiatrist. I see a psychiatrist. I've worked with psychiatrists most of my career, both professionally and personally. So I have a great appreciation for the field. It's a necessary part of it. But I'm also a big advocate for the fact that psychiatry isn't the be-all, end-all, and especially psychiatrists who think they're the be-all, end-all, that they're the ones who hold the key to your mental health, and only they can unlock it, and they just got to find the right medication. And, that might be part of it, but counseling is a huge part of it too, and social supports are a huge part of it. Crafting your own purpose is a huge part of it. So Ian and I talk a little bit about that, and he's so, he so gets those kinds of issues. So, I think you'll enjoy this conversation. I know I sure did. Here's my conversation with my friend, Dr. Ian Dawe.
So, from Newfoundland originally. I've been in Ontario.
I didn't know that.
Yeah.
So I'm jumping in already. I didn't know you were in
Yeah.
Newfoundland.
I mean, that's one of the things that actually appealed to me when I heard your story, because I actually felt that kind of small town type of connection.
What part of Newfoundland are you from?
St. John's.
Okay.
Yeah, and if there was wine on the table, you'd actually hear the accent come out a little bit more than it is now.
Wine and traffic. That's when my Cape Breton accent comes out.
Been in Ontario since 93. I actually came up to do my residency in psychiatry. And then stayed and did a master's degree in health administration and a fellowship at U of T in suicide studies and emergency psychiatry. So I've kind of approaching, I hate to say this, my 25th year in practice. So
congratulations. That's a big milestone.
I mean, it is. It doesn't feel that way. I still feel kind of fresh and young and enthusiastic and very energetic about what I'm doing. Yeah. But I'm apparently referred to as a mid-career person now.
Okay.
Which I'm still getting used to a little bit.
So what's different in psychiatry now versus 25 years ago when you were doing your residency?
I think a lot of things are very different. And the advent of interpersonal, interprofessional, person-centered care has become much more than just a buzzword. It's actually starting to influence the way that we actually work with people, teams, training people to work together better. Is vastly different now than it was before. Those words were used before. Right. I mean, people have been talking about person-centered care for decades. But it's much harder to do in practice than it is
what does
to
that
talk
even
about.
mean, person-centered care? I mean, you would think that medicine, of course, you're treating people, right? Wouldn't they be the center?
They're always the target of care.
Right, the target.
I think that's a bit different than if they're directing or powering around their own decision-making in their care. That's where I think the circumstances have been a little bit different in all branches of medicine.
Sure.
But in mental health and addictions care, it's been that much more of a problem because of these old assumptions that people were struggling with illnesses that would rob them of their ability to make good decisions and judgments. Right. So there was this, as we called it, the benevolent paternalism of we will do to you because, poor you, you're not going to be able to do this.
We know better.
Exactly.
We're the experts. Is there still a stream of that, we're the experts, you should listen to us? Or is it taking root that lived... I heard Dr. Ian Mannion once refer to it as lived expertise, and I think I've heard you say that before.
Yeah,
too.
I like actually the more pro term of living expertise, not lived expertise, because I think that's an ongoing expertise that people bring to their circumstances. And yes, that is a much more embedded and a genuine engagement with people. Like when I was training, it was the advent of the so-called consumer survivor movement.
Right, which was really born out of anti-psychiatry.
Absolutely.
I think,
yeah, very strongly, and in fact. And certainly I felt that kind of growing up and training that people were attacking the profession. And it was, as you say, the anti-approach. And I think that's evolved on both sides.
Yeah.
In medicine and psychiatry in particular have become much more open to involving people in their own care. We still, I think, struggle broadly and historically with those old attitudes of we need to be the experts.
Right.
But there's enough of us now that have been talking about this for a long time that it has become much more accepted and much more mainstream that, in fact, I may be a knowledge or a content expert, but the person across from me is actually the expert,
right.
The expert in their own lives, in their own circumstances, in their own situations. And it's only working together as equals that we're going to be able to do something that neither one of us can do on our own.
Well, and I tell people this all the time. You can't do recovery to people.
Yeah,
you can't inject recovery into them, as nice as that would be. But that's just not the way that it works. So it's actually in the physician's interest then to have that person on side, to have that relationship, right?
It makes so much sense. But I think in practice, people have not been thinking that way historically. They are now. I think that is a much more expected kind of approach that people have the right to demand of their practitioners. And, I think when I was getting into this business and starting that business and people would come to me and they would say, well, you're not like most psychiatrists that I've seen before. That used to be a fairly common phrase because I was talking this recovery type language. Now I don't hear that as much. And I think that's quite gratifying because I assume what that means is that people's experiences are being mirrored outside of just the walls of my office.
Where do you think, in general, and maybe this is a first year med student kind of question or first year psychiatry kind of question, but where, in your opinion, does mental illness start? In the brain and outward into the world, or out in the world and then into the brain?
You'll hate this answer because it's both.
Yeah, sure. It's like the nature-nurture thing, right? It's actually both.
It's exactly that. It is nature and nurture. There are certain experiences that people can have, and you can stack up trauma experiences and maltreatment experiences and just crappy life circumstances on top of crappy life circumstances. And the sum total of those things will weigh a person down to the point that they can become ill. Sure. Some people can be resilient to those things and can survive them with an intact sense of wellness despite circumstances. But it will trip a lot of people up and they will fall into illness. And then on the other side of the coin, there are people who do have biological vulnerabilities, who do start their journees with a predisposition to get ill. And it doesn't take much at all to tip those folks over.
Now, do you think that's a genetic thing? Because it seems like we've moved from the whole chemical imbalance thing into epigenetics and this idea that you might have a gene that gets turned on by your environment.
Yeah, and epigenetics is, I think, the hot topic that really captures that nature-nurture balance. It's not an and/or, it's an and-with kind of proposition that the people that get ill, quote unquote, have probably some combinations of most things. But the purview of mental health as opposed to just mental illness treatment is not just treating the illness. It's actually treating the person, and it's treating their, as much as one can, together with that person and their family units, the circumstances that they're in with too. Because you can do with somebody only so much. The environment has to support their recovery too.
Sure. Now, I mean, many people listening to this might have the reaction, well, and it's an old CBT kind of adage, you can't control your environment, but you control your reactions to it. So you can't always help that you're homeless or unemployed or living in squalor, or you're a young person and your parents just don't understand you, as most young people think, I think. And in many cases, that's objectively true. The parents just don't understand what the hell this kid is going through. How do you then mitigate that? You're treating somebody in hospital. They're in for 72 hours. They come in suicidal. You get them stabilized. They're doing okay. They're not suicidal anymore. But as soon as they walk out the door, they're going back to the same environment that brought them there in the first place.
Well, I think one of the things that has always surprised me is how that reality, how the knowledge that is the case hasn't humbled more people who, kind of think that we are the experts as psychiatrists, because it clearly runs against the limits of whatever power or influence that we have. Right. I can't control somebody's employment status, or I can't control their outside circumstances. But I may know people who could influence that.
Right.
And it's really about me working with a broader array of professionals,
right,
and helping to support all of those areas that are clearly influencing the person's distress.
Yeah.
And maybe that's going to be social service workers, and maybe that's going to be taking on an advocacy hat and walking down to the mayor's office and talking about housing and homelessness and how we work with people in the shelters.
Right.
Or maybe it's going to be me saying, you know what, this is not going to be a hospital-based issue, so I'm going to have to go outside the walls of the hospital and go into the shelter systems, or go into where people are and bring therapy and bring treatment and bring connectivity to them, not expect, like we have historically, that they're just going to come to us.
Well, and this is a good point, because and again, I don't mean to keep harping on this anti-psychiatry issue, but there's another opportunity here.
Again, that was the tradition that I grew up in.
Well, and
so
this is what I mean. Yeah. So there's been historical abuses within not just psychiatry, but medicine in general. Patriarchal systems in general tend to oppress people who are vulnerable. And that in particular, we've come a long way, but it hasn't been that long ago, from chains and hay on the floor and the wall at the Center for Addiction and Mental Health. What do you think that we're doing now that 50 years from now people will say, holy crap, why did they do that? Is there anything that kind of itches like that at you, the types of treatments that we're doing now?
There's lots of things. And maybe it's not treatments per se, but it's just the style that we engage with people. You mean you actually were in an office and you had to make people take a whole day off work to come and sit in a waiting room and wait for you to get what they needed done? I think that will be something that we'll look back on and go, my God, what were you thinking? Because now we're actually doing virtual care. I can, right now, it's still in its relative infancy, but I can turn on a software program that securely video connects me to a person, whether they're in Northern Ontario or Northern Canada or a kilometer away from where I happen to be, and meet them at a time and a place of their choosing, on their terms, in their circumstances. And that frees them up, I think, quite dramatically from having to work under my kind of constraints.
Sure.
We're really changing those paradigms, because people deserve that. People deserve to be met where they and when they are willing to be met, not have to kind of force feed themselves into the box of when the provider is willing to see them. Those types of changes, that's pretty radical in medicine, to be able to kind of look at that. And I see those. I look at those every day. We're building those at Trillium, where I work.
We didn't even actually intro that part of what you do. So you're the
Chief of Mental Health and Addictions at Trillium Health Partners in Mississauga, and an Associate Professor of Psychiatry at U of T. So I
you know what you're talking about.
Well, I don't know. Sometimes I'll grant you that. But I'm living this type of change circumstance. And, I spend most of my professional week actually building and changing circumstances. And I do come from a tradition of, I think, even though it's been schooled in those older styles of mental health, mental illness care, I've also been kind of from a quality improvement lens and a creative destruction lens. And let's think differently, and let's work with different people. And that I think is given me a perspective on saying, hey, if something isn't working, let's actually experiment with something else.
So I find in almost every community that I've either been to or have heard from, and this is true of my own hometown in Cape Breton, Nova Scotia, where there's a rash of suicides, or there's a number of an increase in admissions, or something, or a tragedy of some kind, of some other kind. And the first answer is always, well, we have a shortage of psychiatrists, that we don't have enough psychiatrists. If we just had more psychiatrists, this would fix all the problems. Do you agree?
Sort of. Mental health care, regardless of which particular part of mental health care that you're speaking about, is historically and grotesquely underfunded. I am never going to argue against more resources for mental health. But where I think the challenge has been is trying to build a system around the most expensive and the rarest of the resource. And if you measure the health of a system by its rarest commodity, the psychiatrist, and say, really, that's the only metric that actually defines what good care is, that's a fundamentally flawed system. That will never be efficient, and that will never be an effective kind of scenario. There has to be many different layers of intervention involving all kinds of different practitioners with different traditions and different cost points to make a system effective and efficient.
So it then sounds like you would say that a psychiatrist probably isn't the best person for every possible mental health.
Oh God, no. And I can say that absolutely as a psychiatrist. We are not the be-all and end-all of things. I think we can contribute an important part of it.
Sure.
But for example, at Trillium, so when I hire a new psychiatrist, what I'm looking for is for them to be able to influence not just the 50 hours of professional time a week. So say that's going to get them meeting with 40 people a week or so. That does not interest me. What I'm actually interested in is how that person can influence 300 people a week. What are they going to do that actually broadens and scales and spreads their influence? And now it's, I think, about creating pathways of care, using our highest cost professionals to actually map out what evidence-based care could look like, but then entrusting that other practitioners will accompany that person on the journey and see that more and more people are going to be working through the system. Yes, that is a reality of an underfunded system. We don't have the health and human resources to be able to meet the demand in the way that we're currently constructed. But the answer is not just to kind of throw up our hands about that. The answer is to look at different types of mechanisms of influencing care and spreading care. That's what's intrigued me about virtual care. That's what's intrigued me about working off digital platforms. And yes, they're different. Yes, they might not kind of appeal to the same traditions that people have historically come to expect. But I actually like it when I can tell somebody that, look, you don't need to see me.
Right.
I appreciate you want to see me, and maybe that's kind of what society keeps telling them, that they need to see the psychiatrist. But as a psychiatrist, you don't need me.
So how, just thinking over the I'm sure countless patients by now that you've worked with and had these kind of conversations with, what happens when, okay, great, you get the medication on board, and assuming you've been, adjusting it, you've been attentive to it, it seems to be doing its part as far as you believe that it can, and they believe that it can. Maybe you've got the counseling on board as well, or the psychotherapy, and working through some of the underlying issues there. But you're still missing that other third piece, which seems to be their agency. Maybe they don't believe that they have a role in their own recovery, or they don't, this is always an uncomfortable thing to say to people who are struggling, but you got to do the work, right? You have to be able to do your recovery. Nobody's going to do it for you. So say you got the medication, you got the psychotherapy, but you're missing that third piece. What have been the outcomes, the progress that you've seen with people in that place?
Well, I think part of it is understanding why they might feel that way. And perhaps they've never been in a situation before where somebody has given them the expectation that they're going to participate, or given them the agency that they're going to participate.
Right.
Maybe they've never learned how to advocate or turn on those skills before. And if that's the case, then we can mutually agree, okay, here's some things that we're going to need to know to help equip you to do what you need to do differently. But if we talk about that in that sense of these are just things that you're not doing that you need to do,
right?
That really, I think, will quite admittedly and quite correctly create barriers.
It'll piss people off. It'll piss people off.
Exactly.
Yeah. Well, because then it feels like you're being accused that
Absolutely.
It's my fault,
That's
even
right.
though that's not at all the case.
I don't think that's what it's intended
Right,
to do.
but it feels that way.
In the delivery of it, it should feel that way because that's the received messaging.
Right.
But it's not that way. I think what we're trying to do is to say that we all have a part in your recovery. And I think to quote you, recovery isn't something that is done to a person. You can't just do it. It's a co-creation and it's working together. And it's saying, in every aspect of our relationship as provider and as service user, we're going to be equals in this. And we're both going to have roles. And we're going to talk about those roles and we're going to do those roles together. And I'm going to support you and be with you either face-to-face or virtual or over distance or just in memory about helping to elevate what you can bring to the rest of your life.
One of the tension areas that I see on that seems to be with parents, especially of transitional age or those 16 to 24-year-old kids / adults who have agency of their own, maybe even legally. They certainly have their right to privacy. But they still live in their parents' basement. And they still have to, their parent still feeds them, and mom still thinks that she's the one who makes or who calls the shots and who wants to read the records and who thinks that they should be involuntarily admitted. You hear this a lot, where mom or dad don't feel safe with the kid at home. They don't feel safe for the kids, so they just want them to be in hospital or in jail or somewhere else where they can be safe and helped. How do you? I don't know if you've worked much with kids and parents, but you're trying to develop this relationship with the kid, but then you got the parent here who's pushing really hard for something very different.
Well, and I think there's an element of just working with families, generally speaking, that still has that same level of hopeful expectation that there is a miracle shot out there that's going to fix this. And hospitalization has, for so many years and so many decades, represented this rescue fantasy.
Sure, people go to the hospital to get better, right?
Right. Yeah, that if you can actually just take this person off the streets or you can take them out of the basement and fix them, that they will come back and they will be everything that they're not right now.
It's hopeful.
It's absolutely hopeful. And you have to understand, I think, the wish that will take place comes from desperation, and it comes from the sense that it hasn't been working well. Of course, people will want that.
They just want their loved one to stop suffering.
Right.
They want them to be happy.
As probably the person does too in every circumstance, right? And what we have to work with is the limitations of what hospitalization can provide. There is nothing magical about being in the hospital. In fact, sometimes it's awful.
Yeah.
And we're not just talking about the food.
Yeah.
It is an awful place to be. Right. And it is a protected place that is, for a short period of time, a controlled environment.
Keep you safe,
Maybe.
Well,
yeah,
and that's
maybe.
it. Maybe. So people, you hear about this all the time. If people are going to harm or kill themselves.
It's clearly the most commonly acted on treatment intervention.
Right.
I think we all hope that it's going to be that way, but it's not. And if we talk about suicide-based care, there is not a lot of evidence that actually hospitalization prevents suicide in the long run. It may stop it in the 2 weeks somebody's in the hospital.
Now, media, though, has picked up on this a number of times where I don't feel like it's common knowledge, but basically the standard approach, it seems from my perspective, for something like borderline personality disorder is that you don't admit, that it does more harm than good to admit, usually a young girl who's dealing with borderline personality disorder. However, there's been story after story after story of then, this young girl, for example, presenting at emergency rooms saying she's going to kill herself for the 20th time, being turned away, and then going home and actually killing herself. How do we reconcile this? That the clinical reality is the hospital's probably not the best solution for her, yet there's nothing else.
Well,
right?
I think there's your problem, right? So if there's a mantra that says never under any circumstances do this, only ever do that, that's a situation that's always going to be fraught with risk and danger. So if you're just kind of robotically saying, oh, borderline personality disorder, don't admit, whatever you do, do not bring this person into a hospital, then you're going to miss the fact that this 20th time is different than the 19th time or the 18th time, and that this is actually not just a self-harm kind of scenario, but it's a suicide risk. And those are vastly different kind of scenarios.
How so? Can you walk us through that a little bit, the difference between self-harm and suicide?
Absolutely. So people will engage in self-harm behavior because of being overwhelmed, because they are facing situations that have completely trampled over their ability to cope. And it's complex, and there's multi-reasons. There's probably as many reasons as there are people who self-harm. But no one ever lacks a good reason to be thinking about that in their own circumstances. It's a maladaptive coping strategy. It actually can temporarily relieve the emotional distress if somebody is kind of in the so-called emotional salad spinner, and they're just flipping around with feeling lost and unable to kind of center themselves. The pain of a self-inflicted laceration is kind of like temporarily pressing the reset button and can help temporarily slow that process down.
And that seems to speak to the gender divide, too, that it tends to be, statistically anyway, girls and women who deal with self-harm and borderline personality disorder, whereas men die. Using more lethal means, perhaps, not finding those outlets, even if they're maladaptive.
Historically, that's true. I think we are seeing those gender divides in terms of lethal outcomes shrinking these days. There's more access to more potent medications. There's more access in the world to firearms or lethal areas. So the gender divides aren't quite the same as they used to be.
That's interesting.
But going back to the self-harm kind of scenarios, people engage in self-harm as a way to live, like as a way of coping with what the circumstances are.
Because they don't want to die.
Most people don't want to die when they're self-harming. That's different. People who actually, I'm done, stop the world, I'm getting off, this is over. That is actually rarer. And to pull that out of somebody is about asking different questions and working with them in different ways and hearing their answers differently.
Well, and I've been there too, or actually that's where I was, I think. And even then, only speaking to my own experience, of course, in retrospect, I believed that I wanted to die, but I don't think I did. I didn't want to die. I didn't want to live like I was living.
Exactly.
But I didn't want to die.
Yeah. And I think then you can understand why people become suicidal, because in the desperation and in the feeling that there is no other option, people get trapped and they become defeated and they become in a situation in which there is no viable alternative other than this, other than the notion of ending it all.
Do you think that's ever true, just as a side note, that there's no other option?
I don't believe it's true objectively.
Objectively. And this is what I mean, because when you get in that headspace, your reality is the only reality, right?
And I want to be really crystal clear on that. I absolutely believe subjectively that's what it is for the person who's in that situation. So I would never talk to a person of, look, you're objectively wrong about this.
Right. Yeah, that probably won't help.
Not going to help. And just not true, quite frankly. So it is a matter of saying, I get where you're coming from, and let us kind of work together to discover something that might be different. And, it risks sounding a little flippant about this, and I don't mean it to be at all. But if something less than death can help you in your circumstance, if it's getting a job, if it's getting relationship counseling, if it's doing something else, then suicide as an outcome is going to be overkill. Pardon the term.
Yeah.
It's about finding, not just accepting reasons to think about ending life at its worst, but ending life at its potential best too, and helping a person kind of balance those thoughts.
Well, in some ways, and I feel like once you go through, and my difficult period was as an adolescent, where I was just learning how to deal with life. once you think those thoughts, you can't unthink those thoughts,
No,
right?
you can't.
Then they become memories.
Yep.
And you don't ever forget, at least in my own experience, that you once used to think that way. What I think helped me was when I was able to gradually get to a place where I was able to reframe it and think to myself, yeah, I probably could kill myself. Nothing's stopping me. It's not that hard technically to do, but I could also do all these other things instead.
Right.
And if I'm going to die anyway, let's say that that's the assumption in my mind. If that's my last recourse, why don't I just try all these other things anyway?
Yeah.
What do I got to lose if I'm going
That
to
speaks
die
to the
anyway?
agency piece that
Right.
we were kind of referencing before. And I agree. I think everybody that I've seen professionally, and it's a lot of people these days, I've never known a person to say suicide is not an option. It's not on the table. It may be 75th on the list,
Right.
as opposed to once it was first on the list.
Yeah.
But as you say, once it's there, it's such a powerful kind of thing that it's always going to be there, even as a memory.
Mm-hmm.
But the job is to help a person build up all of those other options and to unlock the solutions that might be getting them to the place of, I only have one option, and moving away from that. The pivot to, okay, I can actually see
Right.
a different pathway is a completely crucial aspect of living and living differently.
I've been fiddling with this idea lately of mastery from a learning perspective, that as you practice something, music, working out at the gym, some other skill, there's that, I don't think there's actually any science behind this, but the idea of, is it 10,000 hours
10,000
of
hours.
practice or whatever?
Yeah.
And the idea is that you're building a neural network by, repeatedly doing that thing and myelinating those neurons and doing all that stuff, that you're reinforcing it until it gets to the point where it just happens, that you don't have to try so hard, it just happens. I've been fiddling with the idea of this is exactly applicable to psychotherapy or recovery or whatever it is, that your myelinated, strong neural network towards suicide, that's because that's the one that you've developed for all kinds of reasons.
All kinds of reasons.
This minor trigger, you shoot down that highway because that's the only thing you have.
It's familiar.
It's familiar. So what if, and it's always very, very hard at first, like any new thing, if you go and try to lift a 100-pound weight with arms like me, you're not going to have much luck. But the more you do it, the better you get at it.
Absolutely.
So you reinforce that neural network until eventually the other one prunes away.
And I think that's absolutely what we're trying to do in the recovery-based approaches to suicide and suicide care, or depression care, or anxiety care.
But
it's
really
a widely
it's-
applicable kind of scenario.
It's really recovery mastery, essentially. You're learning recovery.
People will come and tell me, well, I don't know how to do that, or I'm not familiar with these kind of techniques, and I don't really like therapy, or I'm not that kind of guy who's going to sit and talk. That's just not going to work for me. And I say, okay, I appreciate where you're coming from, but unfamiliarity is not the same as it's not going to work.
Right.
And let's not make decisions now. Let's try to expose together these opportunities that we can have. And it might not be familiar to you, and thus it's really uncomfortable for you right now. But as you get familiar with it, and I've used all kinds of analogies very similar to weightlifting, about just becoming more familiar with circumstance, it becomes easier. And thus the unfamiliar becomes familiar, and then everything's different.
Yeah. In your psychiatrist's mind, do you even instinctively make a note when somebody has that unfamiliarity equals it's not going to work? That's not an inherent connection. Strangeness doesn't necessarily mean failure.
Yep.
But some people, and I do this all the time, do make that connection. Do you ever make a little mental note that that's a piece of information about what that person is going through?
For sure.
Right?
That's absolutely the things that I'm looking for. I'll actually interject with a person and say, I hear you saying it's not going to work and you're not that person, but can I just give you something to think about? Maybe you're just talking about the fact that it's unfamiliar to you.
The fear of the unknown.
Yeah. And change is always something that creates fear for people.
I think for many people, but, and this is something else I've been fiddling with too, that seems to be an attachment style based thing, that people who are used to having or who need, for whatever reason, control over their situation because they've never had any, maybe, or because they feel out of control. So everything that is outside of that needs to be rejected because it's scary. It
Absolutely.
might, I can't control it because it's unfamiliar.
And I think that is where those kind of thought processes come from, and it's where people's adoption of coping strategies, which may not be the ones that are actually contributing to their wellness, come from, because it is what's familiar to them. And I can never criticize a person for that. I can only say, look, that makes sense to me. I get where you're coming from. But perhaps then the answer is to figure out something different, is not just to say, we've been trying that for the last 10 years and it's not getting you where you want to go. I understand you want it to be different, but maybe it's about finding a different way of figuring that pathway out.
Right. Now, I mentioned the control thing too, because when I was suicidal, I think, in retrospect, you never figure it out in the moment. That's when you do the work later. But I think a big part of it was about control for me too, that I partly felt like I had no control over anything in my life, but I could control whether or not I was alive or dead.
Yep.
I really collapsed in on that one tangible decision that I thought that I could make within that dark, confined place. But you are a proponent of and an expert in something called zero suicide. Can you walk us through what that means? What is zero suicide?
So zero suicide is a movement that's kind of really enamored mental health professionals and leaders across the globe over the last 10 years. And it's an aspirational kind of target that says if we could actually redesign or design a system to achieve perfection in this case meaning nobody dies by suicide, nobody dies alone in despair, overwhelmed, then perhaps we should actually try to design the system for that outcome and not be content with gradual improvements and saying that 10% reduction in the suicide rate is going to be fine, that's actually what is a realistic outcome, thus that's what we should be saying.
You don't hear this about, the Princess Margaret Cancer Center saying we're striving for a 10% reduction in cancer deaths.
That's right. That's right. And that's what's personally kind of motivated me and why I've really kind of thrown my hat 100% into the ring on the zero suicide movement. It's designing for best. It's not designing for a little bit better, for incremental change. It's saying, let's actually design the system for 100% success, because it's only in designing for perfection that we're going to get anywhere close to perfection.
Right.
If we design the system for 10%, we'll get to somewhere close to 10%.
Right.
If we design the system for 50%, we'll get somewhere close to that.
But what also seems to be cultural, surprisingly, about this is the very kernel idea that suicide is preventable. Apparently not everybody believes that.
Well, I think there has been a learned helplessness, if you will, for all the things that we've already talked about where the agency of the issues and responsibilities are, where the problems actually are, that we have never been able to influence the suicide rate. The suicide rate in Canada has been kind of stuck for the last 25 years at about 4,000 people a year ending their lives by suicide. Despite new therapies, despite new techniques, despite new medications, that number hasn't changed. I submit it's because we haven't, as a society, decided to change it.
Sure.
And like your cancer analogy, it's when we decide to change, when we decide as a system that this is a target and we're going to actually work to change that number, we're actually pretty good at it as a society. Cancer rates and the mortality of cancer has fallen dramatically. When I was in medical school, AIDS was a fatal disease. Now it is a chronic disease. The mortality of having a stroke is vastly different now than it used to be years ago. All of those rates have changed because we have decided to change them. We've created best practice pathways. There are stroke centers who excel in working with stroke. I envision that the same thing is part of suicide care, that we just haven't yet decided to turn our resources at that target. But quality improvement lenses say, if you want to change the number, you got to target the number and actually kind of work backwards from there. And to me, that's what zero suicide is. It is quality improvement 101. It is taking the worst imaginable outcome of a mental health experience and saying, let's prevent that. Let's actually think about these things working backwards. What would it take to make sure that a person doesn't get lost to follow up? What would we need to do differently to make sure that when they leave an emergency department, somebody calls them within 24 hours and they don't feel like they're alone?
Well, most completed suicides had actually talked to a professional, a healthcare
At some
professional.
point in the last month or so, the numbers are stunningly high. What would it take to make sure that they're getting a treatment that actually is what they need? That they're not just coming into a hospital or coming to an outpatient clinic and being treated for depression and hoping that they're not going to be suicidal anymore, or targeting their panic attacks and saying, okay, you're no longer having an anxiety disorder, thus hopefully you're not going to be suicidal anymore. That's what suicide care historically has been. It's been treating these other things and hoping that the suicide will go down, the suicidality will come down. And that hasn't worked. So zero suicide is about, okay, with this mindset and with this modalities of improvement, what are the types of therapies that directly target suicidality? Dialectical behavioral therapy, cognitive behavioral therapy, not just CBT generally speaking, but a specific type of CBT for suicidality. The newer model called the collaborative assessment and management of suicidality coming out of the US. There are these 3 evidence-based therapies that actually directly target suicide.
When done, though, and this is a thing for CBT in particular, it seems like everybody does CBT or CBT-informed therapies, or but actually done with fidelity to the model.
Very much so. And that's why I say it's not just CBT. It's the specific variant of CBT.
Right.
And those types of therapies are not mainstream. Those types of therapies are not commonly and easily accessible. Thus, that's what zero suicide becomes an opportunity to do, is to say, these are the things that work. How can we actually make them more accessible? So zero suicide is a very clearly articulated 7-step framework to actually creating perfection. And it's saying, look, not one of these things by themselves is going to work. It has to start with the leadership and the sense of the highest people in either an organization or a region. And I'll go as far as to say that's the mayor, that's the chief of police, that's the United Way CEOs, that's the CEO and the board of directors of hospitals, all coming together to say suicide is our target.
Right.
We're going to do something differently. Then it's about step number 2, training people to do good suicide care. And maybe that's safe talk, or maybe that's assist-based training, or maybe it's just mental health first aid. It is these things that allow better conversations and better identification of people at risk. Identification is actually step number 3. It's asking people directly all the time when they're at risk, when they present, are you suicidal? Tell me more about that. Where is that risk? Making that an always experience, not I'm guessing you're not suicidal, so I'm not going to ask, or I'm going to, ask questions around it because of fears that somehow talking about it will make the person act on it.
Right. And it doesn't.
And it doesn't. There's never been a shred of evidence that that's the case. In fact, it's quite the opposite. Step number 4 is about getting those good engagement opportunities. And this kind of comes back to the hospitalization thing. There's nothing magical about coming into the hospital. Most people's experience when they come into the hospital and being suicidal is they get locked in a room and they get watched.
Yeah.
And that's not treatment. That's not engaging. There's nothing therapeutic about that.
It's not active at all.
No.
And I experienced that both as a patient and seeing the doctor for, the 15-minute rounds or whatever, and then doing nothing for the rest of the day. And I've also seen it as a clinician as well, bringing clients in and seeing that nothing has changed.
Nothing has changed.
That's still the same.
And that is, I think, unfortunately, still the most common response when somebody is suicidal. You hospitalize them and wait. There is nothing therapeutic about waiting.
Well, and people don't realize that suicide attempts, even just thoughts of suicide, is itself traumatic. So you're taking somebody who has just been traumatized. Granted, they may have traumatized themselves in a variety of ways, but you're just taking them and putting them in a room and forgetting about their trauma. And you're telling them, no, just push that down. And when you behave, because it's very much a behavioral health type thing, when you stop acting that way, then we'll let you out, then we'll give you privileges, then we'll give you day passes, all that kind of thing.
The command and control kind of history of that, because people didn't know what else to do.
Right.
So they were just going to do what they could.
Are there any actually active treatment milieus? There used to be one, but that's gone now. But you know what I mean, where somebody comes into an emergency room, say they're suicidal, and they're put through a program. Presumably they're willing to participate in it, of course, but rather than just put in a locked room and forgotten about, except for that 15-minute visit from the doctor, they're actually put through a schedule that this is what we're going to do.
That's exactly what we're building, and that's what the Zero Suicide movement has given us the framework, the funding, the interest, and the engagement to build. It's the sense that, maybe it's not going to be hospitalization. Maybe this is going to take place in the least restrictive environment because that actually respects the person as an individual. But it's going to be about engaging them in a therapeutic opportunity. It's going to be about getting them the treatments that they need. That's step number 5 of the notion. It's getting the right treatment and the sense that people can benefit. And then once they finish one step of treatment, it's step number 6 is about closing the gaps and looking and managing those transitions actively, not as it's, again, historically been done, handing a person a piece of paper and saying, okay, call this number and arrange your own follow-up. That's not appropriate. That's not...
most people don't even do it.
Well, because most people don't even know how to do it.
Right.
The system is so
they're scared.
Byzantine and complex that there is no real knowledge about where to go and what to do and who to ask for. So we have to take that responsibility back and transition management and having the organizations or the hospitals or the physicians or the psychologists or whomever say, we're going to help walk that with you and we're going to kind of navigate the system on your behalf. And then it's about learning and continuously looking at data to ensure that all of those things that we talked about, all of the 6 previous steps, are constantly being evaluated, are constantly being looked at. They're constantly being tested to make sure they're achieving what they need to do. The evidence base of zero suicide has been astonishing in terms of reduced suicide rates when it's been deployed at regions and at larger kind of places. 60% reductions in suicide rates, 80% reductions in suicide rates that get actually preserved over time. And I think the key aspect of that is not that it's just one step in the chain being deployed. It's doing all of it. Because doing all of it means that you're actually working together better. It means that you have a capital S system, not a series of small s disconnected systems. That's what we currently have, but what we are aspiring to is this more coordinated, more equitable, more engaging system that treats people genuinely as a participant in their own care and as an active part in their own care. And to me, I think what has attracted me to Zero Suicide is it's been that opportunity to say everything that we've done so far has not achieved the targets that we want to do. And for me, that is a reduction in the suicide rate. Can I say that I will achieve 100% perfection? Maybe not. But if I don't set my sights there, then I'm not even going to get anywhere close to it. But say there's a system out there. I always come back to Henry Ford Healthcare in Michigan, which is where this movement actually first started in the 1990s. Henry Ford was the first group that actually said, we're going to design for perfection. We're going to bring all of the lessons that we've learned in reducing ICU catheter infections or falls prevention or X, Y, or Z, all of the kind of quality improvement science successes. We're going to actually apply that thinking to mental health care with the notion that we will stop suicide. Starting in 2000, right through 2007, relentlessly, year after year after year, the suicide rate came down. And in 2007, they actually achieved 0 suicides. Mm-hmm. And they maintained 0 suicides in their population for 10 consecutive recording quarters as they were measuring it. Nobody had ever done that before in the world. It is an astonishing, exhilarating, incredible achievement. Did they maintain 0? No, unfortunately not. But today, it's still 84% less than where they started.
Right.
And I am constantly surprised by people who say, well, that just proves it doesn't work, or that proves that it's a failure.
Seems like a pretty great success.
That's an amazing success.
Yeah.
An 84% reduction is because they tried to achieve perfect. And to me, that's a lesson. Centerstone, which is a 5-state behavioral health organization in the U.S., has a 64% reduction that they've kind of been working through. The U.S. Air Force has not done 0 suicide specifically, but they've done a similar type of overarching quality improvement exercise. And their rates for active duty personnel and for veterans are 40% less, or slightly less than 40% less, but about 40% less than when they started. Mm-hmm. When you change the orientation of the system and you say that we're going to design it to prevent the worst possible outcome, my impassioned belief is that everything gets better when you kind of work backwards there. I believe 0 suicide is a movement that will actually target the worst case outcome. Mm-hmm. But I actually also believe that people with depression are going to be benefiting from a system that works better together. People that come in with anxiety disorders are going to have a better experience in that more holistic system.
People without any issues at all, I think, would. I mean, I'd be willing to wager that if you took a CBT or DBT program with fidelity to the original model, just stuck it broad-based in schools everywhere, that everybody had to take it, whether you had a mental illness or not, I guarantee you that the skills that those kids learn repeatedly over the course of a year or more, maybe their entire school career, you would see a pretty dramatic change, I think, in the amounts of not only mental health problems and illnesses and suicides, but probably even disruptive behaviors and bullying, and you'd probably see grades go up. Not to say it's a panacea, but that seems like a really simple, straightforward, not all that complicated. Let's get a highly trained person, put them in that school, build it into the curriculum every day.
So that brings me to the so-called Project 0, which is a little thing that we're doing in Mississauga. And when I came to Trillium Health Partners 2.5 years ago now, I came with a kind of quality improvement lens. That's why they asked me to come. And I came saying, I'm going to do a 0 suicide implementation, because I'm a hospital guy. That's what we need to do. And little bit by little bit, slowly but surely, we kind of convinced everybody within the hospital that this was going to be the quality improvement exercise that we were going to work through. And we're slowly checking off all 7 of the boxes of that approach. But there was a unique opportunity that actually became apparent to us, that we could actually do so much more. That this wasn't just 0 suicide for the people that, for whatever reason, were touched by the hospital. Perhaps there was a scale and spread notion that we could actually do 0 suicide for a region. And we started with the city of Mississauga, and we've engaged the mayor's office, and we've engaged the school boards, and we've engaged the public health officials, we've engaged our LIN and our governments. And the notion is, 0 suicide is a great hospital-based quality improvement exercise. But if, again, we really are interested in creating wellness in our society, it's got to be much more than just healthcare. So 0 suicide in the hospitals is a core tenet of what Project 0 is going to be. It's what the hospital will do. But it's also going to be a project that helps align hospital care and community-based care. It's going to be about increasing people's access to dialectical behavioral therapy. It's going to be increasing system navigation. It's going to be reducing wait lists. And if that wasn't enough, it's actually going to push into the school systems. And it's going to work with Peel District School Board was our first partner that's come on board. The Catholic school system has just signed up. We're talking with our private school groups to come on board next. Getting into the school system is about equipping everybody with resiliency-based skills and some of the core tenets of mindfulness and better coping strategies. Evidence-based strategies. But it's acknowledging that, wow, in school, there isn't an access problem. The kids are actually right there.
They're there. They're a captive audience.
What if we went to them and started with equipping them to start their journey into society and into life as adults better skilled, better equipped, better able to manage whatever life is going to kind of throw at them. So Project Zero, builds off the successes of Zero Suicide, but actually starts to create an entire system of wellness. And that, I think has just been an incredible journey to start championing. It's the sense of, my God, if we can do this in Mississauga, if we can actually bend the needle and change the number, crack that nut of the worst case scenario, not by just calling it a healthcare problem, but by calling it a societal problem that we all have a way in. If we could grow a healthier generation, I have to admit I'm always a little uncomfortable using that phrase. But for the point that we're talking about, if people can come out of schools better equipped, then they're going to interface with the community differently. They're going to interface with the hospital differently. They may not need to come at all. And that's actually better. Yeah. Working together is better. So we've developed a 10-year project with the goal that no youth will die by suicide in Mississauga by 2027. It's become a subject of fundraising. Inspired, enthusiastic, really engaged donors have signed up. It's a clarion call in mental health to do something different. And it's attracted a tremendous level of enthusiasm and engagement and senior leader buy-in. Our own CEO has championed this. Our boards of directors have championed it. The mayor's office is behind it. People are engaged in it, because it represents the opportunity to do something different. Yeah,
that big audacious goal of ending suicide in your community.
The big, hairy, audacious goal.
So what would you then say to a young person or anybody living in your community or anywhere else who happens to be listening to this and is suicidal right now?
That there is good reason to be hopeful. You may not see it right now, but we are working hard to figure out how this is going to work with the notion that it's going to scale and spread outside. So this type of approach is going to come to your community. People will be doing things differently. There are things that can create not just tokenism, but genuine, realistic hope for change in the future. And if we can help support you in that journey, then your future can be a lot different than it might be right now.
And that maybe they can even help us to end suicide too.
We would want them to do that. That's part and parcel of it. And we've created in our governance structure, not again just a tokenism approach of patients and families and people coming together to be part of this co-creation. It's not just us going to them and saying, hey, look what we're doing. Can you, check this box? It's saying, here, help us design this system differently. You know what works and what doesn't work. Here's kind of what we're going to bring. What's missing here, and how can we do it together differently? That opportunity to genuinely contribute, genuinely co-create, I think that brings people to the table, and that brings that kind of notion of, this is different. Something's different here.
Something's different.
Maybe it's going to take a little while to see the results of it. I'm not saying it's going to be different on Saturday, but 10 years from now, we are actually in this to be different. And I say stay tuned.
Well, that inspires hope in me. So thank you, Dr. Ian Dawe, Chief of Mental Health at Trillium.
It's my pleasure to be here. Thanks for the opportunity.
All right, that's it. That's my interview with Dr. Ian Dawe, Chief of Mental Health at Trillium Health Partners, a psychiatrist, a really great guy. So I hope you enjoyed that conversation. We went deep in places, and if you're interested in learning more about zero suicide, please do look into it. It's an extraordinary movement with lots of evidence behind it, and Ian could talk to you for days about the evidence behind zero suicide. It's surprisingly controversial, but I think it's something that needs a whole lot more attention. I'd like to ask you my usual favor, my weekly favor. Head over to Apple Podcasts, give us a rating, subscribe. We've got lots more episodes to come of me talking to my friends like Ian Dawe here. You can also check out markhenick.com/so-called-normal. And for news about the show, reflections, blog posts, upcoming guests, whatever. You can also follow me on Twitter and Facebook at Mark Henick, at MarkHenick, for some of my ramblings and silly GIFs. Do you say GIF or GIF? I say GIF. I like GIF. Apparently it's GIF. Anyway, whatever. You can, if you need a psychotherapist, hey, here's that hard transition again. If you need a psychotherapist, but you're scared, you don't know what it's about, you don't have the money, I'm going to give you a 7-day free trial of online counseling with fully certified, credentialed, educated psychotherapists. Head over to betterhelp.com/Mark, enter the promo code Mark, and you're going to get a 7-day free trial of safe, effective online psychotherapy with trained professionals. That's it for So-Called Normal. I'm Mark Henick. Thanks for listening.